Does a restrictive approach to fluid management in critically ill patients improve their outcomes? We'll find out in this episode of Osler Shortcuts. Sepsis is one of the most common causes of death and loss of quality life years around the globe. Hemodynamic management is a mainstay of treatment, and intravenous fluids are an essential component of the Sepsis Management guidelines. Increasingly, however, questions are being asked as to whether or not a more restrictive approach may prevent complications of intravenous fluids, including organ failure, acidosis, and even death. The classic trial, run by a renowned Scandinavian ICU research group, sought to find evidence for this. They included critically ill patients from 31 centres across 8 European countries who had been resuscitated with a mean of 3 litres of crystalloid at randomisation. Patients were randomised to either a restrictive approach, where fluids were only given for specific indications, or a liberal approach based on the existing Surviving Sepsis Campaign guidelines. This resulted in approximately 2 litres less fluid in the intervention group by day 5. The primary outcome, which was all-cause death at 90 days, was no different between the groups. Classic was a well-run study with clear objectives, a high proportion of screened patients included, and incredibly good follow-up. On the surface, it appears unlikely that a restrictive or liberal approach is significantly better than the other. Like all trials, however, Classic has some limitations to be aware of. Classic was unblinded, leaving the study open to bias, as clinicians who were aware of the treatment allocation may have influenced ongoing management, such as diuretic use. Importantly, no estimation of fluid responsiveness was used in this trial. Given that some studies have found up to 50% of critically ill patients are not fluid responsive, some patients would have needlessly received additional fluids, while others would have been needlessly deprived of them. Overall, patients in the intervention arm received only 2 litres less fluids at 90 days, and the control arm had 90-day fluid balance of just 725 mL higher in the restrictive group. This inevitably raises the question of whether sufficient separation has been achieved. The trial was designed to have an 80% chance to detect a 7% absolute risk reduction in mortality at 90 days. The basis for this estimate is not given in the paper, and it seems ambitious, likely leaving the study underpowered to detect meaningful clinical outcomes. Given the effort, time and funding required to deliver important trials such as this, it seems unlikely further research in this area will be produced anytime soon. So like many trials, Classic will reinforce your practice no matter where you stand on restrictive fluid practice. You can read more about this study and related topics such as fluid responsiveness at our website. Just follow the links in the episode details. See you next time on Osler Shortcuts.